sports and activity in general is really important for all of our health and well-being. It's important for our heart health. It's important for weight control, which is a huge issue for musculoskeletal problems. But more importantly, it's important for self-image and mental health. So I think there's many reasons people are active. Everyone should be active to a degree. Unfortunately, injuries do get in the way, and that's going to happen. And it doesn't matter how careful you are, you will have some injuries. I think that's inevitable. Obviously, you can be smart about things. I would say one of our failings as medicine in general is we're not very good at preventing problems. Prevention, partly we don't get paid for prevention, we get paid for treatment, so there's never been a lot of emphasis on it. We haven't made as much ground as we should have. So our goals in terms of a professional here is really to minimize the injury. So once the injury occurs, recognize it, minimize it, don't let it turn into a bigger injury. Treat it early and then prevent these prolonged things. You don't want to end up like one of these people in an interaction. Not that we do that much anymore, but those are our goals. So a few. Again, this is going to be a little more principle-driven than a lot of laundry list of injuries. Most sports injuries don't need doctors. Okay, that's obviously most of you know that. But injuries do need to be treated. They don't need to be ignored. They need to be treated. Most injuries require some rest. On the other hand, we've learned over the last 20, 30 years that almost all our injuries get better with movement and activity to some degree. So the really mantra isn't just rest, rest, rest. It's a relative rest. So it's not no activity. It's a limited activity. It's a protective activity. But you don't want to just stay there and don't move. There's plenty of studies that have been done on what happens when you put an arm in a cast, a knee in a brace, and lock it up and don't move it. It's not good for the joints. It's not good for the muscles. It's not good for the bones. Sometimes, temporarily, you might need to do it, but in general, that's not what you want to do. Movement and activity are important, even for healing. The other thing to think about is that everyone's different. Okay, these are two professional basketball players. Obviously, they're way different. But you look at your buddy or your brother-in-law or your sister, and you see what they're doing, their activities. They're not the same as you. They may be more at risk for injury, they may be less at risk for injury, but they may have a different capacity, and they may recover differently. So just don't assume that it took so-and-so a week, and then they're back, and then it's taking you longer than that. Maybe you have a different injury, maybe you have a different build. There may be a very good reason for that. So don't force it. Not everybody fits exactly the same mold. Our coaches don't always understand that because they always pick the lowest time that they've ever heard of. So someone has knee surgery, and 2 years ago, down at Ohio State, they were back in 7, 8 days. So they assume that everybody gets back within 7 or 8 days. And then when it takes 10 days or 2 weeks or 3 weeks, you can imagine they're not happy with us. They're not happy with anything. So everyone's a little different. They don't expect to be the same as others. One thing I do want you to take away is what are not minor injuries. It's not that complicated, really. And this probably makes most sense to you. But anything that looks out of place, crooked, malaligned, doesn't look right, it probably needs attention. Ankle that's deformed, wrist, anything that just doesn't look right or doesn't move right, moves sideways, moves in the wrong direction, needs attention. So if you see a really lot of swelling or bruising, it occurs early, meaning there's a lot of bleeding, swelling in that area, that's a problem, or if it looks out of line. Anything that doesn't work right. So if before you fell, you could raise your arm just fine, and now you really can't raise it at all, that's probably not just going to come back on its own, probably. You need to make sure that you're not missing a significant injury, because if you treat a significant acute injury early, odds are very good you're going to get a good, successful recovery, because you're just trying to get it back to the way it was. If you wait 6 weeks, 8 weeks, then by the time you get your studies and you see the physician, all of a sudden it's 3 months. That arm's a problem now, because now it's stiff, the muscle's atrophied, and it's a problem. So if it doesn't work, if you have pain and buckling with walking, you should generally be able to walk on most injuries. So if your knee buckles, you fall down, or you can't stabilize your ankle and so on, or if you have a lot of weakness, can't raise the arm, can't bend the elbow and so on, those are not to be messed with. Get that evaluated early on. Or if it's just severe pain, it just doesn't feel right. I think that sort of goes without saying. If it's really severe and you can't sleep and it's going on, those things are not minor injuries. That's not really what we're talking about. Those things really need evaluation, and so we're not going to go over too many of those. The types of injuries that we see we classify them. They're acute, sudden injuries. Something happens, you know when it happened, you saw it happen, maybe it was in your family member or your son or someone, occur with a specific event. They can be major or they can be minor, but occurs suddenly is what we, acute injury. And then what we see a lot of also are chronic injuries that are more cumulative. They slow. You don't know when it started, but you realize that for the last month, 6 weeks, 3 months, your knee hurts, your shoulder hurts, or something like that. So you don't know what the mechanism was. Maybe you're a runner, maybe you sort of have a hint at what it was, but you can't pinpoint exactly what that was. Sort of we call those chronic or more delayed onset injuries. And those are important. I'll come back to they're probably not as different as we think, but they kind of present differently. It's important to know how things heal. So if you know how things heal, then you know what to expect, you know how to recover, you know when to do certain things. So when you have an injury, your body naturally has an acute, we call inflammatory or reaction, often swelling, some bleeding, some bruising, but it's inflamed, it's hot, there's a lot of activity. So that happens right acutely, and that's part of the healing process. Once that occurs, you get into more of a repairing process. So more cells, more blood, more nutrients go to that area. We can see it on fractures. We can see it. So here's a pointer here. So this is an arm bone. So shoulders here and elbows here, and that's a fracture healing. All that fluffy stuff is new bone that's formed. So that's all these cells coming together to do this repair. That's obviously not very strong at this point, but that's sort of this repair process. And then later on, it goes into a remodeling. So it gets its strength back, and then it tries to get back toward normal. And again, bone is probably the easiest for us to see, where you may end up with this initial fracture, and then it remodels and looks more and more like a normal bone. And that whole process is really the phases of healing, where you're returning to normal, you're returning function. And this is what guides our treatment. So shouldn't be such a mystery why we treat things a certain way, because this guides our treatment. For example, in the acute phase, this is when you want to do this so-called RICE. You've all heard this acronym for rest, ice, compression, elevation. So you're resting it, you're not moving it around, you're letting it settle down. Ice to reduce some of that swelling, early inflammation that you get. Compression also to reduce the amount of swelling, and elevation, again, usually above the heart to get the swelling down. Then you move into a repair phase where you want to protect the injured structure. That may be with a splint or a brace or an ace bandage or something, but you generally want it to move. You want to start getting function back, because that actually improves the repair process. So if I took one knee and put it in a cast for 6 weeks, and another one that I put it in a brace and allowed it to move, the one in the brace would actually heal much better and much faster, because that actually stimulates the healing. Do you have a question?
Quick question on bullet 1 up there. I read somewhere that people have a tendency to want to put warm...
So we'll get to that in a second. Okay, hold on. So as you get into the remodeling phase, and you're trying to get the function back to the tissues, the flexibility, and so on. And you're getting into some heat, range of motion, and starting into some strengthening, and then a progression back to activity. And that doesn't mean you start by throwing fastballs. That means you may start going through a throwing motion. You may start with a heavy ball just to get that motion back, and then many of these things, there are progressions, and you can find these online. Like a throwing progression might start with 20 feet and then go to 30 feet and then progress over time so that you're coming back in a logical way.
When you say compression, do you mean an ace bandage? Is that what you mean?
Yeah, ace bandage or a pull-on sleeve. There's a variety of different devices. some sort of, there are some ones that actually squeeze it and pump it, but they're expensive. You can actually rent them. But so back to your question about ice. People are always asking, should I put ice on it or heat? Well, early on it's ice. You don't want to put heat on it and make it all more swollen for the injured structure.
How long do you put the ice on? 10 minutes every hour or what?
Well, it depends on the injury, but yes, usually it's on and off because you can actually get a skin problem if you put ice on for too long. So you've got to watch that. You can put something between the ice and the skin, a towel, and have a little bit longer, but you can put on a fair amount of time if you watch the skin. But usually it's about 20 minutes, and then you have it off, and then let the skin warm up. So that sort of guides our treatment. Now, I want to mention this early on. Overuse is actually kind of like an acute injury, except what happens is it's a much smaller acute injury. So you didn't realize that by serving that one more serve, you actually tore a little bit of your rotator cuff. You didn't really feel it. It wasn't that big. But what happens is that's trying to heal. Then you go out and you play the next day and the next day, and you don't allow it to heal. So right as it's trying to recover, boom, you injure it again, and you injure it again, and you get this cycle of recurrent injury on top of a healing effort. And what can happen is you get basically a failed healing process. The healing just stops, and sometimes it's hard to get it restarted. We'll go over that a little bit for something like tennis elbow, which otherwise known as lateral epicondylitis, but you can get those kind of things in multiple areas of your body, even in the bones. The stress fractures, those are overuse injuries where you have an acute injury, but you never let it to heal all the way because often you don't recognize it. It often occurs if you're trying to ramp up faster with your sport activity or something. So that's something to keep in mind. Now I just want to go through the tissues, because if you understand how the different tissues heal, it sometimes helps you figure out what's going on. And in orthopedics, we're mostly dealing with bone, muscle, ligament, tendon, cartilage. Those are the ones, and different combinations of those as well. But those are the things that you're really talking about here. Bones are the simplest, actually. It breaks. All familiar with a fracture or a break. It can be partial or it can be complete. And then you can get a stress fracture, which is basically a small fracture that you don't allow to heal, and then you use it again, and it just progresses. So this is, you're familiar with what a regular break looks like. I showed one of those earlier. This is what a stress fracture might look like on an x-ray. This is a foot, so that's the big toe here. This is a metatarsal stress fracture, so-called march, from marching, soldiers marching fractures. You can get those in multiple metatarsals. Probably the most common place for a stress fracture, and they're quite painful, but you don't always know when it occurred. They do weaken the bone, so sometimes you'll get a break all the way through a stress fracture. Most bone injuries heal pretty well. That's sort of the good news. Some, if it's out of alignment, need some surgery or something to line it up, usually a plate or a metal rod or some device to hold it out. Sometimes we can use a brace or a cast. And importantly, they heal with bone tissue, so they regenerate bone. So bone's a wonderful, wonderful tissue, unlike other things. If you have an injury to the brain, or we'll talk about injury to muscle, you just generally get some scar tissue in there. You don't get normal tissue back. In the bone, you can actually get normal tissue, so that's a good thing. Muscle injuries are typically called strains. So we'll talk about sprains, which are ligament issues, and strains, typical muscle tendon injuries. And they go, in my business, you can only think about three things, grade 1, 2, 3. Get too far, you don't want to make it too hard. So, minor, moderate, severe, or, basically these are a really small partial tear, a bigger partial tear, and really a complete tear. That's sort of how we talk about it. This is a picture of the leg, and showing the back of the leg here, the gastroc muscle. Very common tennis injury called tennis leg is a tear of the muscle from a sudden push-off. Muscle tears, and it's painful. Sort of the good news is most muscle injuries heal without surgery. We rarely do a muscle operation. First of all, you can't repair muscle. It's just like soft stuff. You can't actually do any good surgery on it. But the problem is that there's a high incidence of re-injury, and we're all familiar with baseball players or football players who keep getting hamstring pulls or quadriceps tears. Those are muscle injuries that just keep recurring. They recur because you heal with scar tissue. It's susceptible to re-injury. Often there's a return to activity because the function comes back a little too early without proper getting ready, and the muscle injury recurs. So that's the biggest problem with muscle injuries. They heal, but they recur. So you really, to prevent that, you need a slow, progressive return to activity. So a program where you're running. Now, if you're getting paid $1 million or $2 million or $10 million to play baseball, you may not have that option. And I think the players and the owners have gotten smarter about that. So you see these really long loss of activity, but that's why, because they recur. Ligament injuries are called sprains. Okay, ligaments are these strong tendinous structures that run from around the joints from bone to bone. So this part of the bone to this part of the bone. This would be an example of a knee, and we'll go over this kind of in more detail later. Medial collateral ligament sprain or tear. Partial is grade 1, and then complete grade 2, or severe, where it really whole thing displaces, would be a grade 3. So they leave, as you can imagine, the joint, if it's a complete tear, somewhat unstable and loose, so it feels like it's going to buckle. Common ones are in the knee, in the shoulder, in the elbow, and most of these can be treated with a brace, control the motion, control the forces, and allow it to move, and they heal pretty well. Not all of them, and we'll go over intercruciate ligament injuries, which are a common problem that don't heal well. Cartilage is a wonderful structure, and opposite of bone, it just doesn't like to heal. So cartilage is this wonderful structure that covers the ends of your bones at the joints, sort of that white material at the end of the bone. And it's sort of this gel-like tissue that's filled with water and a few, not very many cells, and some complex proteins that when you squeeze it or put weight on it, it actually leaks a little water out of. So it's really slippery. That's what makes your joints really slippery. And you have cartilage on either side of your joints that make your joints move painlessly. There's no nerve fibers, there's no blood vessels in here. So it gets all the blood, all its nutrients, its oxygen and its glucose and everything from the joint fluid. So you can imagine movement is important for this. They do not like to be immobilized. This is, I don't know how well that shows up. This is what it looks like when we look in with a scope or a camera into the joint. This is a knee, cartilage on the top, cartilage on the bottom. This is a probe we use to feel around in there. But it's a nice, white, smooth, slippery surface. You can get partial thickness injuries like this. This is an MRI of a kneecap. So this is the kneecap if you cut it in cross-section, showing normal cartilage over here, and this thin, the bone is black, and then the cartilage is this darker gray, and the white is fluid. You can see here where the white comes almost all the way up to bone, doesn't quite get there, but that's cartilage is missing from that area. So imagine just taking this and shearing it off. And unfortunately, this does not recover. This does not heal. And that's the problem. That's the problem with joints. That's the problem with arthritis. The tissue does not regenerate, and we really struggle with that. You can get a full thickness injury where that goes all the way down to bone. Here's a picture of a lesion at surgery where this is normal cartilage, this again in the knee, and then this is the defect with basically bone at the bottom of the defect. And it's very hard for us to get these to heal. We've got certain techniques, but none of them work great. How do you know if you have a joint injury? Stiffness of the joint. Swelling is probably the biggest sign that you might see, sort of water on the joint or fluid on the joint. But if you have that, you generally have stiffness. It just hurts to move. You sit for a while. Everyone's had this once in a while. You sit and you get up, and it just takes time for your knee to respond because there's fluid in there. The fluid's got to move somewhere, right? Who's an engineer? You were an engineer. You know. Oh, someone's an engineer. It's like a damped hinge, and it takes a while for the fluid to move, so you feel stiff. Again, poor healing capacity, and often these require surgery, but we really don't have good results. I'll be honest. This is an unsolved problem in our field. We're not good at fixing cartilage, and that's why we end up going to knee replacements and things like that are not ideal either, but sometimes necessary. Question?
If you tear a rotator cuff or your knee, what is the crunching noise from? No cartilage?
Well, So the question is, what's the crunching noise in when you move a joint? And it depends on the joint. In the knee, for example, it's typically the cartilage on the kneecap isn't smooth anymore. So instead of looking like this, it looks like a shag carpet. One of my professors when I was in Boston would always tell his patients it looks like the Bruins just skated on it for a whole period. So it doesn't look smooth anymore, and then you take pressure on that and you move it. Then the shoulder, it's a little different because you can get some rubbing up against the rotator cuff, and I have a shoulder example later we can look at. Sometimes the clicking and crunching are not bad things. We don't get too excited about that.
What are the meniscal tears? Where does that fit in?
I'll get into that.
Oh, okay.
Oh, I was going to ask what the meniscus is.
Okay, I'll get into that too. Okay. Get to some more specific. So let me tell you about joints, because this is another important concept that you need to understand how to protect yourself and how to treat injuries. So everyone's familiar with a basic joint, right? This is an elbow here, basic elbow muscle, and a weight. Okay, so let's say in this example you have a 10-pound weight here, right? That's not too much, not too little. Well, what happens to the rest of the joints? What happens is this is a big lever. So they work like levers, and if you know how a lever works, you use it to take a small force at one point, and it becomes a big force at another point. So what happens is it's a 10-pound force here, but to get 10 pounds here, you have to have a lot more force back at this point. So you may have 50 pounds now at the elbow. So when someone says, well, I'm not hurting my joint, I'm just lifting 10 pounds. Well, you're lifting 50 pounds on the elbow. And if you get to the whole shoulder, you may get up to 200 pounds at the shoulder. So we have these guys coming in and they're lifting pounds and they're lifting a lot of weight and their shoulders are bad. And they wonder, why are their shoulders bad? They never hurt their shoulders. Well, they've been lifting weight for 20, 30 years. We see all these people, they're 40s and 50s and their shoulders are arthritic and they're built like, very built. And they say, well, I don't really lift weights. And they have, and that's all they really want to get back to doing, and it's a really hard problem. So the point is, what you do is magnified at the joints. And that goes for your body weight too. So if you think about going up and down stairs, 6, 7, 8 times your body weight across your kneecap when you're going up and down stairs. So if you have 10 extra pounds, you've got 60, 70, 80 pounds more on your kneecap, and that's important. Now obviously it's a lot more complicated than this simple model, and there's all kinds of other forces going on. I'm not saying this is as simple as it is, but that's sort of the basic concept. It's magnified at the joints. So if you're like this young man here, who knows what his joints are going to be like in the future. But people wonder, I'm not lifting that much, but my shoulder hurts. So think about that. Now, because of how joints move or how they work with the cartilage and no blood supply, movement is necessary to keep the joints healthy. So you basically, you want movement, but you don't want a lot of weight. So the truth is some people are built different than others, or they have different genes than others, and some people can do it. Some people can lift weights their whole life and never have arthritis. Some people can smoke and never get cancer. Some people are different, but in general, you can't all do it. So think about that, and especially limit the weights if you have a problem. So if you have a history of a joint injury, you had a cartilage tear one time, or you had some sort of joint injury, or you have a family history of arthritis. And the easiest question that we ask is, has anyone in your family ever had a knee replacement? If they have, you probably got a history of arthritis. Now some people have just, toughed it out and never got their knee replacement and they have arthritis, but that's often a way. If that's or if you have pain and swelling in your joints, you should not be a weightlifter because you're just magnifying that problem. Your joints are not healthy enough for that kind of activity, and you want to go into more repetitions, movement with lower weights. Lower the weight across the joint because it's all magnified. So now let's talk about some injuries. We sort of got some of the basics down. Let's talk about some of the simple injuries. And then we can, if you have questions related to that, try to just rule. It was hard to know what injuries to present, but let's start with some simple ones. Every one of us has had an ankle sprain, right? You roll the ankle in, you take a misstep, the ankle goes inward, I think. Anybody not had one? Oh, you're lucky. But very common injury. where the ankle gets rolled in here, and you tear these ligaments on the lateral side of the ankle. So most of the ones going from the small bone, the fibula, down to the foot. So you tear those lateral ligaments, and you can do a little minor one or you can do a severe one. They come in different degrees, as you can imagine. It makes the ankle a little loose, and can make it loose. But with a brace, you can control that, and actually you can fairly early get back to activities if you let that heal. If you think about it, just putting weight on the joint squeezes the bones together. That doesn't hurt the ligament at all. It actually takes some of the tension off the ligaments. So weight bearing's okay. You just don't want to re-injure it. You don't want to roll it again, and you know that it's more apt to roll because it's looser now. So wearing some sort of brace, and more evidence is that some sort of brace that allows the ankle to move up and down in a good motion rather than putting it in a cast, putting it in something that's going to make it rigid. Occasionally we'll do that for a severe sprain, short term just to help with the pain, but generally motion is good to let that heal. And then you can get back to activity pretty quickly. Little simple ankle sprain, we let people get back within days, certainly a week or so. That's not a big deal. So that's sort of the most minor injury, and it should heal really well. The only problem we get into is if you do it over and over and over again, eventually those ligaments get stretched out and don't heal very well. And occasionally we'll need to do a procedure to repair or tighten up those ligaments, but that's a minority of times. Now, you've all heard of the high ankle sprain, right? That's seems to be a more common injury you hear about because a lot of the players miss time for that, especially football players, because it's common with football. So what is a high ankle sprain, and why don't they get back quickly? It's really a different injury. It requires more energy, so it's usually more of a tackle kind of thing. You didn't just roll your ankle. You usually got tackled. This is the typical mechanism, and you may not see it very well, but this is the foot here, and this is the leg. The foot gets forced outward, gets rotated out. Take the toes and turn them away from the other foot, and often gets trapped like this, so you can't, there's no way to protect yourself when something like that happens. And the ligaments, now instead of these lateral ligaments, the ligaments between the two bones tear. So the bones basically get pulled apart, this tibia and fibula bone, and now it's high because it's really above the ankle. And this can spread actually all the way up the leg and then break the smaller bone, the fibula. So sometimes we see it associated with a fracture all the way up by the knee. But really it's an ankle injury. So that's the problem. Now you can imagine what happens if you try to walk on that. It pushes the bones apart, and that really hurts. Or if you try to push off, you can't do it. So it's much harder to get back from this kind of injury. You can't weight bear, you can't push off. It's a bigger problem. So the recovery time is much more prolonged. It's slow to heal. It's frustrating. It gets recurrent injuries. And occasionally they're so bad, if those bones drift apart, they have to be next to each other to heal. So if they drift apart, we actually have to do something like this with a screw or two to hold those bones together while the ligaments heal. And then we take the screws out, and then it's all done, because the screws will break, if you leave them in. So this happens, once a year with our football team. We have to put screws in on somebody, so it's not uncommon. But that's the high ankle sprain. Does that make sense? Different animal. Now let's move up to the knee, and we'll get to the meniscus. So let me tell you about knee cartilage. There's two types of cartilage in the knee. The type we talked about, the so-called articular cartilage, or the hyaline cartilage, that coats the end of the bone on the femur and on the tibia, right? So that's one kind. And then in the knee, and in a couple other joints, there's something called a meniscus. Meniscus means moon-shaped. That's what it's named for. They are these semicircular pieces of fibrocartilage. It's a slightly different kind of cartilage, and there's one on each side. Okay, and they cushion and they stabilize the joint, but they're prone to injury, and that's where we get into problems. So you typically tear the meniscus with a twisting type injury. You can see, I don't know if you can see all the way down here, but there's a bunch of different types of injuries that they get. You can get kind of a split one way or a split another way, and those become painful. And the problem is, as you see in the picture above that, this is depicting sort of where the blood supply is, the so-called red zone. We keep it simple in orthopedics, red and white. So a red zone means there's blood supply there. It actually looks red when if you tear it or cut into it. And then the white zone, which means there's no blood supply. Blood supply typically is necessary for adequate healing. So the ones on the inner edge, like this one down here, probably won't heal very well, and those become symptomatic. Ones that are on the outer edge can heal, or we can repair those. But these are much more likely to be painful and to require surgery to treat, to either remove the torn portion or repair that. Now, the problem with the meniscus is that these tears occur more commonly as you get older. They occur more commonly because the meniscus gets weak with wear and tear, aging, regular activities. And then it's prone to tearing with a minor activity like tying your shoes or bending over or getting out of the car. It's also associated with knee arthritis. As you get arthritic, the meniscus gets involved and you can get tears associated with that. And treating the meniscus doesn't always treat the arthritis problem. So that's one of our problems is people have arthritis, which is their main problem. They also have a meniscus tear, and figuring out which is causing most of the pain, and is it reasonable to treat the meniscus tear, or will that just not make any difference? So pain is what we rely on. The pain can be off and on. So people can have pain for a week, and then it can go away until they twist it the wrong way, and then it can hurt another week. It goes away. If it's gone more than it's there, then it's fine to live with. If it starts to interfere with all your activities and things you like to do, then sometimes you need to have that treated. We use arthroscopy, and I don't know whether this is going to work. There we go. So this is what we see when we're looking with a scope. So we're looking through a small camera. We're actually not looking. It's shown up on a monitor, and then we have another hole where we put an instrument in, and this is the femur up here. This is the tibia, and this is the tear. You can see this is in the white zone. It's white. It's not going to heal. It's on that inner edge. It's never going to heal. So we remove that torn edge because that torn edge gets caught and pulls. And we have different tools, different sizes, different directions. This is a little biter. It looks sort of like a Pac-Man. Goes in there and removes that loose edge. And we only want to remove the part that's torn. The meniscus helps to distribute weight in the joint. It helps to cushion the joint. And we don't like to remove any more than is torn. And then we just sort of smooth off the rest of it. We're doing this underwater, so that's why it looks kind of, everything's floating around. That's what we use to distend the joint so it pushes everything away. And we then, again, have a bunch of different tools. This is a little shaver that actually sucks things in and cuts them off. Again, it's all underwater, so you'll see things get sucked into this shaver. And we do a lot of our surgeries now arthroscopically or minimally invasive because you can see, we can see very well. It's much easier than seeing through a little tiny hole. That's just what we used to do. I mean, I never did that way, but my father was an orthopedic surgeon. He did it that way, and then they would just take out as much of that meniscus as they could. That was the goal. Get it all out. The more, the better. So we've learned a little bit. We can see it better. We can do it better, and it's obviously much less invasive in terms of recovery. So that's the meniscus tears. Now, closely related to that is knee arthritis, and knee arthritis being the knee being the most common location for significant arthritis. And we get it in our hands, and you get the knobs on your fingers and things like that, but that's usually more of a nuisance than it really is a problem. The knee is a real problem. It's the most common joint that's affected. What happens is the cartilage goes through a whole series of events that ends up with the cartilage basically going away, peeling off the joints, leaving the bone exposed. And if you remember, that cartilage layer had no nerves, so you can't really feel anything in your cartilage. It's just smooth and pain-free. You have nerves in your bones, and so that starts getting to be exposed bone. That starts to hurt with weight bearing and other things. So this creates pain. It creates a swelling reaction in the joint, and it's just bad. So the most important factors in this are your family history. We talked about that. You know, did anyone in your family have a knee replacement? Whether you had an injury in the past, unfortunately. Injuries, even years ago, seemed, in some people, start a cascade of degeneration that so far we don't know how to protect. We may learn in the future how to protect that, we don't know. Weight. Now weight is often disguised with, not disguised, but it's adjusted for your size. So you have a body mass index, and that's sort of a measure of your size, because some people are tall and big and so on. So that's a measure, but if the higher your body mass index, the more force you're putting on these joints. And then interestingly, the knee alignment is a really important thing, and I just had this little picture here. This is sort of what the knees are supposed to look like. Sort of when you put your feet together, your knees are supposed to go together, okay? Mine don't. My knees don't touch when I put my feet together. That's probably a bad thing, but if you're shaped in the ideal person, which there's not such a thing, your knees come together and your feet come together. And if I had a ruler and I drew a line from the hip down to the ankle, we'd go right through the middle of the joint. So your weight is distributed across both sides of your knee. The medial, one side is the medial, one side is the lateral. Now, if you're bow-legged like I am, where you put your feet together and you still have room between your legs, and you draw a line, where does the weight go? It goes on the inside of your knee. And that's the way most people are put together, especially most men, bow-legged. We call it varus, just I guess a Greek term. And that predisposes you to wearing out the inside of your knee, because all the weight's concentrated on the inside. So it's not distributed, you overload the cartilage. And you can imagine what happens when it starts to wear out, you just get more and more and more bow-legged. So it just makes the problem worse and worse once it gets started. There certainly are people who are knock-kneed, a little bit more commonly women, but can be either. And just the opposite, then you get wearing out actually on the outside. So this is more common. This is actually probably often worse and harder for us to treat. But those are important factors. And if you're lucky, your legs are straight and you don't have a family history and you're not overweight, you're probably not going to get arthritis. But most people have one of these factors associated with them. Often I'm asked about running. Is it safe to run? Do I ruin my knees by running? Generally, if you have good knees and good alignment and you don't have these things, you can probably run without causing any problem. Now, if you do have these things, like many people do, then you can cause some more damage by especially excessive running. So running's good to a degree, good for your heart. If your knees are pretty good, you don't have a problem, seems to be good to run. If you have a problem, if you have some early arthritis, then you need to look to other things. Doesn't mean you can't run, but you need to look to cross-training, look to something where you get the weight off your knees, whether it's biking, swimming, other things, or lower impact. To improve the joints, if your joints aren't the greatest, what do? Low impact activity. Remember, movement is good. Joints like movement, so they don't like to sit on a couch. They like lower impact activities. That can be a bike, that can be swimming. Actually, the elliptical, I have some knee problems. I have a family history of knee arthritis. I've got bow legs, so I don't run. It hurts my knees. So the elliptical is actually great for that. Question?
If you have recurrent ankle sprains,
Yeah.
should you be running or walking?
Well, it depends. If you sprain your ankle when you run, then you have to either figure out how to prevent that. Right? So you can wear a brace, strengthen the ankle. But if you keep spraining it while you're running, you probably shouldn't be running.
No, I mean playing sports. If you have recurrent ankle sprains playing sports,
Right.
would it be better for your ankle to run or to walk?
I don't think the ankle cares about that, about strengthening. I mean, I don't think that makes a difference, as far as I know. There are some specific ankle exercises you can do. But I think if you can, I don't think it matters. Hills are bad for arthritis because just like more weight, it's more force. It's often knees bent at a little different angle, and so you need to keep it level. And again, repetitions are good. Heavy forces are not so good. So if you have an option of going really slow and cranking hard on the bike versus spinning faster, which both may get your heart rate up, you're better off spinning faster with a lower force. It's better for your joints, especially if you have some predisposition to arthritis. So the ligaments in the knee, so we're moving from cartilage to ligaments, are common injuries. And you hear about these. You may have had a friend or family member with a ligament injury. It's very common. The ligament injury, the ligaments can be a little confusing, but there is a way to just keep it simple. There's basically side-to-side ligaments. So if you think of your knee just as a post of two things coming together, You need to control that side to side. So there's a medial ligament on the inside and a lateral ligament on the outside. Keep it from going side to side. I mean, that's sort of seems pretty straightforward. Of course, it's a little more complicated than that, but that's basic. And then there's front to back ligaments, because the knee can actually go front to back too. Those are called the cruciate ligaments. They cross in there. The cruciate ligaments are in the middle of the knee, so they're hard to get your fingers on, they're hard to see. The collaterals are more on the outside, a little more obvious to examine and so on. So the collateral injuries occur when you get run into. Typically, you get run into from the outside. It's occasionally people get run into from the inside, but it's pretty unusual. Usually the foot's on the ground, you get run into. The knee's got nowhere to go, so this ligament on the inside tears. Completely or partially, medial collateral ligament. It's a broad, relatively thin ligament that heals well without surgery. So that's a good thing. Some sort of controlled brace to prevent it from keep getting re-injured, but allowing it to move. So this is, rather than a cast, a brace is much better because the movement actually helps the ligament heal. And you'll see a lot of players, now some of our players actually wear these to prevent this injury. There's a whole debate about that, but they probably do prevent some injuries. And then a number of players wear them after an injury as part of their recovery. They don't love to wear them. On the other hand, the cruciate ligament tears, especially the anterior cruciate ligament tears, is a different kind of tear. It's usually a non-contact injury. It's usually landing or cutting, sort of a sudden thing. No one's pushed them, no one's hit their knee, and all of a sudden you see them kind of crumple and go down and hold their knee. That's often a cruciate ligament injury. It doesn't look like very much, to be honest. Interestingly, it's more common, if you adjust it for the sports, more common in women, soccer and basketball, very common women and young girls injury, unfortunately. And it can look like this, where the ligament just shreds, it just tears, kind of like taffy, pulls apart. This is an MRI, so this is what an MRI looks like. This is the femur, this is the patella, the kneecap, this is the tibia. And the ligament, you can see a little bit of it down here, but it's faded away. See, ligaments are black, like these tendons out in front. There's no good ligament here. This is a diagnostic of an ACL tear. So often we do get MRIs because we can't see these. It's a little harder to feel inside the knee. And so an MRI works really well for these injuries. The problem, and the reason this is a big deal, is that they just don't heal well. There's a lot of debate about why, whether they float around in the knee joint fluid or whatever reason, but they don't heal well, and they leave the knee a little loose. Now that's okay for walking around and often working, but for landing, cutting, pivoting, the knee will slip out of place. It'll buckle, it'll give way. So if you don't do sports, you can live fine with your anterior cruciate ligament torn, but if you do sports, then you usually can't. And so that's a problem. And if you try to force it, you start getting re-injuries, and then you injure the cartilage and the meniscus.
How are knee ligaments different than wrist ligaments? Are they different? Can they heal?
So the question is, how are knee ligaments different than wrist ligaments? And no, they're the same basic structure. Wrist, if you've ever seen a wrist x-ray, there's a whole bunch of bones, right, that come together. So what that means is there's a whole bunch of ligaments, because every bone has a ligament to the next bone. So there's a lot of ligaments in the wrist, and some of them heal just fine. But like the anterior cruciate ligament, there's a few ligaments, especially some of the ones between the bones, that don't heal well. And the bones will rotate out of position, and they're small, they're buried inside the wrist. We're not good at fixing those ligaments. So yes, they can heal, and most of them do heal, but some of them don't. And that's the ones that don't are the ones that become problems. And actually, we don't have a really good solution for that, as you may know. The anterior cruciate ligament, because it doesn't heal, and because a lot of people that get these are already active in sports and want to be active in sports, they often need to be repaired so they can get back to sports. We do that basically by putting a new ligament in place of the old ligament. We've tried to repair it over the years, stitch it back together. It would make sense. It just doesn't work. So what we found is you actually have to put a new ligament in place of the old ligament. So this is just one way of doing it. You drill holes on each side and you put a piece of ligament in there. You actually have to use a reconstruction. So we're taking a new ligament from somewhere else and replacing the old ligament with that. So you need to get that. And then it becomes down to, well, okay, where do you get that from? So that's often the controversy in anterior cruciate ligament surgery is where do you get the graft from? How do you drill the holes? And that sort of thing. The basic principle is you need a new ligament in place of that. And you can use a tendon from around the knee. You have to take it from somewhere. You can use one from the other knee. Some people like to do that. I don't like to do that. Or you can use a cadaver ligament. But the problem with cadaver ligaments, they're someone else's, they don't heal as well, and they're more likely to re-tear. So there's no perfect solution to this. The bottom line is we can fix it, you can get back, but it's a long recovery. So everybody basically misses a season of their sport, which if you're a college player and you sat out your first year and you're borderline your second year and then you tear your ACL, you don't have that much time left. So you can get another year sometimes. Sometimes you can't if you've played so long, so it becomes a big injury. Question in the back?
If your ACL has been missing for a lot of years, like 15, 20, do you ever do surgery?
So if the question is if your ACL is gone, chronically torn, and we see that all the time, because sometimes you don't know you did it. I mean, knee swells up and you sort of ignore it or you get back or it wasn't as well recognized in the past. What do you do now? And bottom line is a lot of people can function well without it if you're not doing those kind of sports. If your knee's buckling and giving way and swelling, then you've got to either stop doing those activities or get the ligament fixed. So in general, you either modify your activities or fix your knee. And either one of them are okay. So if you're living with a torn ACL and your knee's a little loose when someone pulls on it, but it doesn't bother you, that's okay. We generally don't fix them late. And if you start having other problems like arthritis, then it's too late. It's not really worth going through that surgery. Anyway, you have a high chance of returning to activity. So the good news is what we tell the teenagers, that's what happens. You usually get back to sports. The bad news is you miss a season. It takes a long time. Nobody's happy with that. It's often the seniors in high school or the seniors in college, and they're really disappointed. So before I move to shoulder injuries, we'll go over just a couple more injuries and we'll have some time. Ooh, I'm running out of time. I'll go over these quickly, okay? So shoulder injuries, that's what I do mostly, treatment of. Just a brief anatomy. This is what the shoulder looks like. The ball and the socket is covered up here by the rotator cuff. So the deltoid, the pec, the bigger muscles are removed. This is the rotator cuff, which wraps right around the shoulder. The bursa is right there on top between the tendon and the bone. So that's the sort of basic anatomy. The most common problem is a tendinitis. It can also be a bursitis. They're right next to each other. The bursa and the tendon, we don't really differentiate. They both get inflamed. And what that really is, it's a partial tear. So it's a partial tear that just doesn't heal, usually compounded by another injury, lack of rest, the things we talked about with this overuse, where you just don't let the injury heal and you get a sort of a chronic inflamed, irritated tendon, usually from overuse. Sometimes there's a clear reason, like a bone spur. So this bone up here is called the acromion. Sometimes develops a large spur on it. This is an x-ray of it. And you can see this big spur pointing right down into where the tendon sits. So something like that, you're much more prone to get a tendon problem because it's getting crushed by that bone spur. So sometimes there's an anatomic reason. Sometimes you get it on both sides because of that. That's just how you're built. Generally, this can be treated with a specific exercise program, some degree of rest, again, not total rest, relative rest, and an exercise program. And then if you have something like this, you often will need a surgery. So about 3/4 of people can be treated without any surgery. Sometimes we end up doing a surgery to remove a bone spur or something like that. Rotator cuff tears are a little more complicated because now the tendon actually breaks through. So the tendon breaks through, the muscles pull the other way, so the tendon can never go back to where it came from. There's a gap there. This is what it looks like in a drawing. This is what it looks like in an MRI scan, same kind of thing. Here's the muscle over here, here's the tendon, and it's uprooted or pulled off the bone. You can see it's not going to go back down there. Now, So the basic concept is these full thickness ones that go all the way through the tendon don't heal. You don't always need surgery. A lot of people do live with small tears, but if it's consistently painful, raising the arm overhead, weak, pain at night, and so on, or if it seems to be getting bigger and getting worse, sort of like a tear in a fabric might get bigger, then you need to get that fixed. We do this now mostly with an arthroscopic repair. So this is looking, if you can imagine, sort of looking where that arrow is, looking down on the tendon. This is tendon here, this is bone here. There shouldn't be this hole here. So we clean off the bone, we pull this back together, we put stitches and stuff in and get it to heal. But again, it's not a quick fix, 3 to 6 months. Nobody really wants to do that unless they really have to. Sometimes you have to. Common procedure. Finally, tendinitis. It's really common in the elbow, so-called lateral epicondylitis, tennis elbow. If you've got it, I know right where to push, right where it hurts, because it's always in the same place. We see it over and over and over again. And really what it is, it's a tear. We call it tendinitis, but it's a tear. It's a tear of this muscle attachment to the elbow. It's the muscle that goes basically across the elbow and across the wrist. So it goes across 2 joints. So it's prone to a lot of stretching. It's not the strongest muscle because it pulls the wrist up. Your stronger muscles are on the front. They make the grip. But to make a good grip, actually you have to have both muscles working. So even when you go to grip something like a jug of milk or whatever, you have to use these muscles and it makes it hurt. So you get this tear, it starts to heal, then you re-injure it, and it starts to heal, and you re-injure it, and the same thing, and you get a chronic non-healing tear there in this. It's called the extensi carpal radialis brevis. It's always in the same place. And this recurrent injury prevents healing. And again, what starts as a minor problem because it's not sort of dealt with, it's not rested, it's not rehabbed, becomes a longer-term problem. Usually you can do some stretching. This is one kind of wrist exercise you can do. It's not lifting heavy weights like you're lifting iron. It's just some small muscles, but critical to get that. And rarely do we do surgery. We just don't usually have to do that for this problem. So I'm done. I just wanted to briefly review, the things that you want to pay attention to if you have an injury or anyone has an injury they know of with deformity, it just doesn't look right, loss of function, it's weak, it doesn't work right, or there's a lot of pain. That's something that needs to be dealt with early on. It may not end up needing treatment, but if you just ignore it, you may end up taking a treatable problem and making it into a much more difficult problem. For that rotator cuff problem, if you wait 6 months, it's much harder for us to get that to recover than if you treat it early on. Again, ice and relative rest, not total rest, you don't have to lay around, you don't need a cast, is best at first. Then support, brace, something to control the motion, but motion and using it is a good idea afterwards. And then the heat and strengthening, and then a progressive return to the sport that you want to do. So if you're going to go play tennis, you don't just go out and start playing tennis. You simulate the motion, and we do this with therapy, but you can do it on your own. You can take a band and you can simulate serving, you can take a ball, and so on. So I'll end with that and open it to any questions, and then I'll stick around afterwards for a little bit. So thanks for your attention, appreciate it. How about all the way in the back, sir?
Yeah. This one that's a meniscus tears with arthritis. I got that, and I see they give the treatment with injection. Why?
Right, okay, so injections for knee problems, right? So
she says too that the doctor said that with my foot, I got arthritis too.
So what do we use injections for? I think that's a great question because they're really common. In general, we're not fixing a problem with an injection. We're treating symptoms that are associated with the problem. Usually some early arthritic change, maybe just some swelling, but you're treating the symptoms. So the simplest injection is a steroid type injection, cortisone type injection. Cortisone is a potent inhibitor of inflammation. So the idea is it gets swelling down, it gets the joint lining hopefully to make less fluid. So if your knee's swollen, that swelling comes from the joint line and overacting and making too much fluid. Sort of trying to do the right thing, but not. So if you can get that knee to stop making so much fluid, it'll feel better. Doesn't fix the underlying problem, but it makes it feel better. The other kind of injections that are used are these so-called viscosupplementation. That's sort of a big word, but it's basically taking joint-like fluid and injecting it into the knee. And there's a couple sources. The original one was really from the rooster comb. How anyone figured that out, I don't know, but chemists are doing all kinds of things. And they found this material that's found in joint fluid. They said, what if we inject that into joints? And it turned out if you inject that into joints, it tends to make the joints feel better for a while. And now there are synthetic versions of that because some people have allergic reactions to those. So, there's a big market, so the companies all have these different products. They're probably all about the same. But the idea is to lubricate the joint, to try to get the joint settled down. And, there's a big debate about how much it tends to help some people. Like anything else, it helps some people for a while. It doesn't fix the problem.
So surgery is better?
That depends. Sometimes you need surgery to treat the problem, and that's a tough. That's right. I mean, a lot of people are on the fence: surgery or no surgery. Surgery can certainly make things worse. There are lots of risks with surgery, from infections to blood clots to other problems. So, the way most surgeons view it, we have to be really sure that surgery is going to make you better to make it worth doing. So if you're kind of on the fence for these kind of problems, generally you're not having surgery. And it usually becomes pretty clear if you can't get to the grocery store, you can't take care of yourself, you can't get around, you're taking pain pills all the time, that you often need surgery. So often patients and what they're able to do are a better judge of it than the surgeon. Not that we don't look at the x-rays and decide whether to do surgery or not. Okay, go ahead.
I'm sorry, we've talked a lot about football players, but I want to talk about seniors.
Seniors?
Seniors, yeah.
Okay.
Now, I'm pretty active. I saw you about a year
No
ago.
football
I
players
had
here,
No, not like to watch football. But I was doing, I had a meniscal tear doing Zumba, and I switched to doing line dancing. And when I do anything, though, I have to do it with gusto. If I don't, then
You choose to do it with gusto.
I choose to do it
Yes.
with gusto.
Okay.
Otherwise, I want to sit and read a book.
Yeah, okay.
And I wonder if you could kind of give me some guidelines for that. My other question is, with a rotator cuff, I have a brachial plexus from birth injury, and I had a little bit of a tear. So it's hard for me to detail when it's a severe problem.
Well, I think the first question with how much gusto to use. I think when you see those videos, exercise videos, there's always the person going like crazy, all right, and then there's a person kind of medium, and then there's a person kind of going slow, and frankly, everybody is a little different, and you may not know till the next day what you did, but you generally, if you're hurting the next day, you're probably doing too much. Too much, okay. Right? If you hurt a little bit while you're doing it, the muscle soreness. You're tired, that's okay, but you can't get out of bed or your knee swells, that's too much. Okay. And your shoulder, if you have some inherent weakness, if you have an old nerve injury, then typically you're using some muscles more than they're normally designed to be used, because you have other muscles that are weak. Okay. So you have sort of overdoing it with some muscles, and they may not like that. So that's probably what happens, and it's hard to get around that. And you've just lived with that. And how about the gentleman in the sweater? And then
in the recreational athlete, so the rest ice compression elevation strategy, is there efficacy for doing that after the swelling has disappeared, you can no longer see it? Is there evidence to suggest that you should continue to ice and compress even after it's gone down visually?
So I don't think there's much evidence after that. I do think if you can tell, especially after exercise or after a day of work or whatever, that area is still warm, hot, and that can go on for quite a while. You can feel it, you can see it, sometimes it looks a little red. Then it's reasonable to do some ice post-activity to prevent that. Because whenever you exercise and you do things, your blood supply goes up and often to that area, so you might get some swelling after activity as you're getting back to doing it. But if you don't see any swelling and you don't feel a warm joint, I don't think there's any evidence that ice really helps at that point. Right behind you.
What are common women's volleyball injuries, and what might be done to prevent them?
So what age? Girls volleyball, the most common problem we see with girls volleyball is girls that have loose joints, especially loose shoulders, and which is really common, frankly, because shoulders move a lot, so it's naturally tendency to have a loose shoulder is very common. And then you're hitting something with a lot of force at with that kind of lever arm, and it's sort of like a pole vaulter. You know, if you bang something up here, the bottom of the pole wants to move, so it tends to shift the shoulder and make the shoulder hurt from that. So that's one of the common problems we see in girls volleyball. Now that's hard to fix. Maybe that's the ones that come into the office because they don't get better. There are some rehab exercises we do to try to strengthen the smaller rotator cuff muscles right at the shoulder to keep it stabilized. And then obviously with jumping, you see problems, in front of the knee, in the kneecap and in the tendon that runs from the kneecap down to the leg, patellar tendon. So you get, if people are still growing, they actually get some growth, some pulling off at the growth plate. Osgood-Schlatter's is a sort of crazy name, but that's what it's called. Or patellar tendinitis. So those are the main problems. It's from the jumping and from the hitting. Question, how about right here, and then we'll go to the other side.
Hamstring issues. Can you tear your hamstring?
Yeah, you can certainly tear your hamstring. There are multiple hamstring muscles, first of all. So unlike the quadriceps, which is really one muscle with multiple parts, there's really multiple hamstring muscles, and you can tear any one of them. Typically, you tear one of them and not a whole bunch. And the most typical injuries are in the middle to lower part of the muscle. And just like a muscle in the leg or others, it just pulls apart. And it'll heal, but it's prone to re-injury, so you want to really have good flexibility, and then you want to get the strength back before you go back to those. Usually it occurs with some sort of explosive activity, a sprint, lunging for something, so you want to go back in a controlled manner with some weightlifting, some really good conditioning before you go back to those activities. But the more serious hamstring injuries, you can actually pull it off the bone right up at the pelvis. Those are typically water skiing injuries where the whole body gets lunged forward, and those often need surgery. Actually, it's one of the rare kind of muscle injuries we do surgery for. How about in the back? I'll work my way around.
Do you typically recommend that people with ACL reconstruction wear a brace if they're playing a sport that caused the injury?
So should you wear a brace after your surgery, basically, as you come back to sports, right? And so there's a big debate about that. There's no evidence that it helps, so I would say I don't know. We've tried to look at that. We do know that if you wear a brace, it kind of messes with some of the muscle reaction timing in your knee. One of my partners has done a lot of work on that. He believes that the braces sort of screw up your stretching of the muscles and the way the muscles work. Generally, we don't recommend doing that. Some people, it's a traumatic experience to go through one of these surgeries, and the recovery and getting back to sports is really kind of emotional, and it's scary. And some people feel better wearing a brace, so we don't have a lot of evidence that it's bad. So we will let, if they want to, wear a brace for a little while, or if they do a lot of side-to-side, like a football player, they're going to get hit on the side. But I would say in general, no, you don't need a brace, if it worked. Sir?
Like that gentleman said, do you have some fluids that you can inject to make the movement better? Is there a procedure to replace cartilage?
So the question is there, especially if the injections don't work, can we replace cartilage? We can replace a lot of other things. And as I mentioned, we're not good at that. So yes, the answer is there's always someone that's willing to try doing something. But the cartilage replacement procedures are okay for basically a pothole in your cartilage. Pretty normal cartilage with a piece that gets knocked out or missing. I showed you a picture of that. So that was a surgery to fix that cartilage because the rest of the cartilage is pretty good. And there's been a couple things that have been tried. There's really two popular, let's say three popular techniques. One is very simple. You scrape the bone and you poke holes in the bone to get to the cells that are inside the bone, in the bone marrow. Hopefully there's some cells that can sort of do anything they want, sort of like stem cells in the bone. They come out, they form a clot, and they form a fibrocartilage patch over that. It's called microfracture or drilling, and it works okay. It's pretty simple because you just scrape it and poke some holes in it or drill some holes in. That's been used for years, works okay. Not great, but it's simple. The other technique is to actually take some of your good cartilage, biopsy, send it to a lab where they grow it into more cartilage cells, and then you come back another day, you sew a patch, thin sort of skin over that hole, and you inject cartilage cells underneath there. That sounds great. As you can imagine, it doesn't work that well. How long do the cells last? Do they actually stay there? Do they squirt out? Does it really heal? And there's a lot of debate about whether that's worth doing. The other way, which we tend to do a little more often, is take plugs of cartilage and move them from one area where you need them less to that area where you need them more. But you need them everywhere, so you're sort of robbing one place to move it somewhere else. And sometimes the holes are just too big to do that. We'll often take a cadaver knee or joint and take a plug out of that and put it in. But it's dead bone. It's not ideal. So none of them are great. And that's the bottom line. And none of them work well if all the cartilage is bad. So if you've got arthritis where you've got a bad spot here and a bad spot there and a bad spot there, which is 99% of what we deal with, it doesn't work at all for that. So I don't know where to go. How about you? And then we're working our way up there.
For a senior over 80 that's in pretty good shape, would you recommend knee surgery?
I guess I don't know how to answer it. Yes. We do plenty of people over 80 and over for knee replacements. 86. It depends what if their health is good and they really have disabling knee pain, yeah, it works. It can work well. But again, you're weighing the risks of a surgery. You're talking about a knee replacement, I assume. Yes. So, the knee replacement results are 90+% good results. So that's pretty good, unless you're one of the 10 that has some sort of problem. An infection is a disaster because the knee has to be removed on antibiotics, and it's a huge problem. Blood clot in the leg, is serious. It can become an embolus. It can kill you. So there are major serious complications. Fortunately, those are 1% less or less, so they're not that common. But you have to make sure the problem is bad enough to go through those risks. But the results can be spectacular. So I think if they have enough problem, they're pain every day, can't participate, can't enjoy things, and often people say they're just not themselves because of it, and it's good for them. All right, moving forward in the red.
If you're prone to spurs in your shoulders and other joints, is that genetic or is that from old injuries?
That's probably genetic. Yeah. Spurs come with arthritis. You get this form of osteoarthritis, which is wear and tear arthritis. In addition to thinning of the cartilage, you get bone spurs. We call them osteophytes, little at the edge of the joint, sort of knobby fingers, knobby knees. They go along with osteoarthritis, which very commonly runs in families.
And that limits range of motion?
Yes. Yeah.
Is there surgery involved, possibly?
Yeah, usually not just for removing the bone spurs. Usually it's a joint replacement because that's really the fundamental problem. The bone spurs are kind of a side problem that add to that. But when, for example, if you went through a knee replacement, the bone spurs are removed at the same time. Other question over here? One more over here.
Well, my particular problem is a tight IT band, and daily stretching helped the symptoms quite a bit. I've heard that to actually solve the problem, there are certain muscles I need to strengthen. Now, is it true that I should be looking for muscle imbalances and correcting those?
So this question is about the IT band. IT stands for iliotibial band, or runs down the side of the leg, really all the way from above the hip, across the wide part of the hip, where it can cause one set of trouble, so-called bursitis at the hip, all the way down to below the knee. So it runs a long way, and it's makes that sort of firm outer part of your leg. And is your problem more at the knee or the hip? The knee. So it kind of windshield wipers back and forth across the knee. If you're a little bit bow-legged, it makes it worse because you're kind of pushes the knee out that way. So yes, we try stretching. I don't know that that's effective at all. I mean, we try it. If you looked at it, it's a tight band. I mean, I don't know that there's any stretching that really helps that. I don't think that strengthening any other muscle all of a sudden relieves that tension. I think the only things that are really effective are treating it directly, so you can ice it, you can get an injection. You can limit some of the motion, you can change the bike seat height and things like that. And some people do well with actually, if it's from running, from modifying how their foot hits the ground with an orthotic so that it doesn't get pushed out consistently, lands a little bit better. So those are things we try. And then occasionally we'll actually do a little release or lengthening of the band. It's a little unpredictable, so we don't like to do that, but that's sort of the final resort. Make sense? I think we'll just take some questions up here if you guys have any. I appreciate you guys coming. And come back. We're back here. Someone's back here next month talking about golf, I think. So.